All right, so today I'll be discussing conditions that are really pervasive in chronic SCI and some of our work on potential therapies for these conditions. I'm going to talk about several studies, so I'll acknowledge some key collaborators along the way and forego any formal upfront introduction. Also, I'll likely not notice some of the chat boxes as it goes on, so I'll address any of the questions probably at the end of the lecture. Okay. All right, so the fact that we can discuss chronic conditions in SCI really is reflective of this significant shift in mortality rates. SCI survival over time can really be attributed to, advancements in medical practices, operative and surgical treatment strategies, and just overall better rehabilitation. However, all right, so slowly. When compared to those without an SCI, here it's shown at different age groups, life expectancy is considerably less and progressively worsened with more severe injury. As you can see, there's a decline in this graph here. So this is actually taken from the National Spinal Cord Injury Statistical Center, and I'm showing it here because we also use it on our Miami Project website. So this introduces the concept of aging with SCI, which is really understood to exacerbate physical and physiological declines, and in general is an accelerated multi-system pathology. I think that in this audience specifically, we can appreciate that which systems and how significantly they are affected is going to vary depending on the level as well as the extent of the neurological injury. And we often think of, in general terms, of outcomes with respect to the somatic system, specifically sublesional muscle and skeletal systems, primarily in terms of sensory-motor deficits. We also think of autonomic systems, respiratory and cardiovascular, mainly with higher levels of injury, as well as the GI and urinary systems, and we describe them in terms of bowel and bladder function. But a deeper look at these and other systems as well show many, many hallmarks or outcomes, and these can all lead to specific pathologic conditions when we're thinking about things that are happening and occurring chronically. I won't detail all of these. I just wanted to give an overview. Notably, I've highlighted here myopenia or muscle loss, as well as fatty infiltration into sublesional muscle, as well as bone loss and fatty infiltration into sublesional bone. They create this shift in lean to fat mass, which actually results in this persistent metabolic derangement. Contributing to this, which I've added here, is the fact that fat tissue itself has a reduced capacity to burn fat or to oxidize fat just at rest or in response to a stimulus. And although I won't be talking about it today, we actually have a paper in review right now showing dysfunction in nutrient cycling also contributes to metabolic dysfunction. So all of these contribute to what we describe as an obese somatotype. And obesity, just FYI, is considered as a disease standalone. Again, and this really creates this stark shift in metabolism. And if we also reconsider that neurological injury, again, well understood in these in this audience here is the considerable inflammatory cascade or the cytokine storm that happens. Well, this also happens in the periphery, such that many of these outcomes have a strong inflammatory component. So highlighted here in red. So together we have like obesity, metabolic issues, as well as systemic inflammation, which are now understood to worsen two particular systems, the cardiovascular and the endocrine system, such that what is described as cardiometabolic disease, or CMD, is one of the leading health concerns in chronic SCI. So we can pare down the risks that are really noticeable in SCI, and unsurprisingly, obesity is among them, as well as impaired fasting glucose, dyslipidemia, and hypertension. Again, hypertension will be level of injury dependent. There are some emerging risk factors, outright insulin resistance, low HDL with respect to dyslipidemia, as well as the accumulation of the inflammatory reactants, CRP and IL-6. So why is this important? These result in premature coronary heart disease and diabetes. And if we revisit that life expectancy chart, greater than 50% of death is attributable to coronary heart disease and diabetes in chronic SCI. So this is a big problem. Unfortunately, we tend to simplify the main contributing factors into deconditioning of sublesional tissue, immobility, and nutrition as the most significant confounds. So our current strategies to deal with these confounds include rehabilitation, primarily neuromuscular electrical stimulation and functional electrical stimulation, but they really look and work on motor outcomes and have very little known effect on these CMD risk factors. Exercise as a strategy is actually the only one that has defined guidelines to specifically address these CMD risks. And most of this work was led here at the Miami Project by Dr. Nash. Diet is something that is more recently been given consideration, and we've integrated that into some of our integrated programs as well. So generally here, I would continue onward and discuss how we've used these strategies and share our data on improving risk factors. We've actually published on our integrated program in several different clinical trials and shown the efficacy to reduce these CMD risks. But the issue is, or the reality is, that there are challenges that do remain. For example, there is a phenotypic change in sublesional muscle from type 1 to type 2. This limits the utility of modalities such as FES due to fatigability. Exercise response with respect to these risks, although very promising, is still limited and is quite varied. We still don't have guidelines which really allow us to understand the nutritional requirements. And overall, there's this clinical paradigm which is just to use the existing risk models. And I think in this arena, it's increasingly evident that different risk factors, as well as how they present, are more important in this population. So moving forward, I'll pivot into how we wanted to look to improve these strategies. So, big picture, to address these limitations, we wanted to start from the beginning. And I thought this would be a good kind of like recap and educational slide here. If we look at a roadmap of translational science, there's this basic direction from preclinical to human to practice to community to policy. I think we're all a little bit familiar with that. What I've been describing with respect to these cardiometabolic disease risks are really outcomes research where findings can readily be integrated into guidelines, practice, and policy. But it also gives us the opportunity, to examine things in animal studies, where we can look at defining underlying mechanisms, targets, and perhaps lead molecules. All these things can be done. And as a center where both animal and outcomes research is being performed, we thought that would be valuable to do both, which kind of led us to want to do these animal studies to begin with. So the data in the studies hereafter will be in reference to a mouse model. I'll describe specific details as I go on, and I discuss specific studies. But in general, we're using a murine model. It's an infinite horizon contusion model. We perform severe SCI at 70 kilodynes at T9, and the injury control is really sham operation. So this is just your basics, and I'll be modifying it as I go on. Oops, sorry. All right. So this is still background. This is one of our first exploratory studies, and we wanted to examine the underlying biology of obesity. Why? Because it is a well-defined process. The hallmark biological feature of obesity is leptin resistance, which is also considered an inflammatory process. Leptin is an adipose tissue-derived cytokine. Physiologically, it is released after feeding, and it will initiate or signal satiation, if you will. So normally, or physiologically, leptin signals in the arcuate nucleus of the hypothalamus via its cognate receptor, which is a type 1 cytokine receptor, and it will activate JAK-STAT signaling pathways, basically to signal satiation. SOX3 is a negative regulator of this process. With leptin resistance, this entire pathway is downregulated. Actually, the leptin receptor is downregulated, and the whole thing is turned down. As well, SOX3 will be turned up. In conjunction with that, ER stress proteins are upregulated, specifically IRE1, PERK, and EIF2 alpha, and their upregulation contributes to inhibition of this pathway. So we wanted to test in our model at 30 days post-injury, which is considered chronic in our model, and also to compare this to aged mice. Again, likening SCI to an accelerated aging process, if you will. So these are our analysis, is Western blot analysis, showing significant decreases in the leptin receptor and activated signaling intermediates, JAK-STAT, as well as an increase in the negative regulator SOX3, both with SCI and in aged mice. We also see a significant increase now in the activated ER stress proteins, IRE1, PERK, and EIF2, also in SCI and aged mice compared to the sham control. This is evidence now for leptin resistance in this inflammatory process. So building on this, we wanted to evaluate leptin signaling as well as other inflammatory processes in peripheral tissues associated with cardiometabolic risks. So leptin signaling in the heart is actually pathological when signaling is upregulated. Leptin signals this time via JAK-STAT as well as P38 MAP kinase to induce pro-inflammatory, oxidative, and apoptotic tissue damage, specifically TNF-induced contractile dysfunction, CRP, IL-1 beta, and IL-6 induced vascular damage, and in just general progression of heart failure. So in addition to this, in both visceral adipose tissue and the pancreas, the NLRP3 inflammasome, its formation and subsequent activation of caspase-1, IL-1 beta, and IL-18, which are known as well-defined components of obesity and frank diabetes, respectively. We wanted to examine all of these in our model, and this was done in collaboration with our resident inflammasome Pumbaa, Dr. Keen. So again, we wanted to test these processes in our SCI model. And we saw that the leptin receptor and its signaling intermediates in the heart were significantly increased after SCI, and this is chronically, again, 30 days. And with SCI, we saw an increase in the activation of caspase-1, IL-1 beta, and IL-18 in both visceral adipose tissue and the pancreas. So altogether, this is evidence of leptin-mediated cardiac dysfunction and inflammatory hallmarks of both obesity and diabetes. So we've established some underlying mechanisms here, right, for obesity and inflammation, and we've done so in several tissues. These studies were important for several reasons. One is that we show these mechanisms in our model at a time where body mass is actually normalized. It returns to baseline. So the excessive gain in mass, which we see in the human condition, is actually not a prerequisite for these obese mechanisms. And it may limit tools that we use, such as BMI and waist circumference. Also, these mice are just generally good feeding regulators. So excessive nutrient intake, which we also see in the human condition, is also not a prerequisite. And we also understand in this model, and we see that there is a spontaneous degree of motor recovery. And by 30 days, they're moving around a lot. So outright immobility is also not a prerequisite. So what does this mean? That reduced understanding, or that a very simplified understanding that I alluded to earlier in the clinical paradigm, is actually insufficient. And it suggests that looking at SCI-specific hallmarks may be more important to investigate, especially with respect to these risk factors. So still, we haven't done any experiments that directly examine disease. But luckily, as we published this data, they laid the foundation for us to get funding to do so. So our first real directed study, the objective was to directly examine cardiovascular disease, specifically atherosclerotic disease, or AD, I'll call it from here in, as well as potential inflammatory components of disease, and evaluate an anti-inflammatory therapy. So this is just to give you an overview of the study here. This project, it was funded by a Nielsen Skirt grant, and our primary collaborators were in DRI, Doctors Armando Mendez and Angie Sveto. So again, we use our basic model, our CI model, but instead of using wild type mice, we're using a ApoE knockout mice. Now, the ApoE knockout mice is a widely adopted model of AD. It rapidly develops atherosclerotic lesions and histopathological features that resembles human AD, including the progression from fatty streaks to intermediate lesions into fibrous plaques. So we performed a time course analysis at 16, 24, 28, and 28 weeks, where we generally see lesion onset and progression. We superimposed an injury at 16 weeks. And in another group, they were given injury as well as the anti-inflammatory salicylate, which we delivered 30 days IP. And so these are general group comparisons. So a little bit about the disease, how we measured disease. We extracted heart and aorta intact, and we fixed the tissue. And then it was prepared en face, as they call it, which is basically just exposing the luminal surface. And we then stained the tissue, or the aorta, with oil red O, which is a lipid stain, from which we could get percent lesion area and quantify that. And the aorta is separated and can be quantified in different regions: the aortic arch, thoracic, and abdominal area. So for inflammatory analysis, we used a cytokine chemokine multiplex panel of 23 analytes, and we analyzed main effects and interactions assessed by a two-factor group by time 2A ANOVA. We also performed regression analysis using significant analytes as predictors of AD, and hypothesizing that there is a major inflammatory component to AD. We wanted to test the anti-inflammatory. In this case, we used salicylate, which is a non-acylated salicylate, which is an NSAID related to aspirin. It's an NF-kappa B inhibitor, and it's shown to reduce inflammatory markers such as IL-6, TNF-alpha, CRP, as well as lessen mechanisms related to atherosclerosis. So this is our basic outline of the study. So here's our first look at AD. Here in the A panel, we have our stained aorta and the produced digitized image. And in B, we have these group prevalency maps for each group across the time series. So we have ApoE at 16 weeks, and we have all groups at 20, 24, and 28 weeks. So in this image, you can already see that there is an increase in, just to the naked eye, in lesion area at the later time points. So for quantification, we narrowed it down to the aortic arch region, as this area is most highly correlated with AD mortality. So a small preamble here. As we move forward through this data, there were a lot of statistical interactions. So I really just pared this down to highlight some of the main statistical points. So here, this is just what we describe as the native trajectory of AD lesion in our ApoE mice, which is progressively increased over time, and this is significant as well. An SCI superimposed caused more disease, which was significant at 24 and 28 weeks. And with salicylate, there was a reduced SCI effect on these AD lesions. So this suggests that there's an inflammatory component to AD, which is caused by SCI, and that it can be attenuated with anti-inflammatory treatment, in this case, salicylate. So we then aimed to assess group differences for a panel of these inflammatory cytokines and chemokines. This is just a very busy supplemental graph, which really shows that we had consistent results for all these analytes within detectable ranges across all groups. But of these, only 5 of the analytes showed significant main effects or group time interaction, which I'll discuss now. So I'll briefly highlight the important group differences, starting with IL-1 beta, where we see significant increases in IL-1 beta due to SCI by 28 weeks. For IL-6, we have significant increase in SCI at 24 and 28 weeks. And for TNF-alpha, this was significantly increased with SCI at 20 and 28 weeks. And here we see that salicylate has a significant effect on reducing the SCI-induced increase at 20 weeks. Similarly, for MCP1, which is a monocyte chemoattractant that, as the name suggests, it regulates migration and infiltration of monocytes to lesion sites or inflammatory sites. And here we see that SCI induces a significant increase at 20, 24, and 28 weeks. And lastly, for CCL5, which is also a chemoattractant, which recruits leukocytes to inflammatory sites, we see that it is significantly increased with SCI at 28 weeks. So notably, we don't really see a quote unquote significant reduction in many of these in the salicylate group with respect to SCI, statistically speaking, but we do see a lot of trends to do so. And in general, the ability of salicylate to offset SCI-induced increases in these analytes. But recall that there was an overall significant effect of salicylate at 24 and 28 weeks, suggesting that the net effect of this NSAID has a positive effect on disease outcome in general, as a bigger take-home message. So, and generally speaking then, if we think of what biomarkers are included in these risk models for AD or atherosclerosis, we think of things, cholesterol, triglyceride, blood pressure, hypertension, obesity, so on and so forth. But there's really still a lack of comprehensive understanding as to whether or not or what inflammatory markers should be included, especially when it comes to confounds such as with an SCI. So to start to understand this better, we ran prediction models to see what analytes may predict lesion. So first we performed a simple linear regression for each of the analytes, the 5 analytes, across all groups, and we found that all were significant positive predictors of lesion. When we looked at the coefficients, IL-1 beta, IL-6, and TNF-alpha, so the first 3 here, these first 3 models, they were the strongest predictors. And given that these cytokines and chemokines in general will collectively mediate some sort of immune and inflammatory response that would accompany AD, we also performed a multiple linear regression. And in the integrated model, IL-1 beta and TNF-alpha were the best predictors of lesions. So overall, this suggests to us, these results suggest that IL-1 beta and TNF-alpha may best predict lesion when modeled either individually or collectively. So to summarize some of the significant data of this study so far, SCI actually accelerates aortic atherosclerosis. The anti-inflammatory treatment with salicylate was able to attenuate the impact of SCI on AD outcomes, as well. The pro-atherogenic inflammatory cytokines, in this case, IL-1 beta, IL-6, TNF-alpha, MCP1, and CCL5, may be effective predictors of disease or lesion. So these data are really evidence that we need to reevaluate some of our rehabilitation and therapeutic strategies to address these risks at a much earlier time point, given that we're seeing this accelerated trajectory. So shifting gears somewhat, a parallel objective was to revisit sublesional muscle, but by looking at muscle-sparing therapies, and doing so, though, through the lens of its effects on global metabolic issues. So we actually ran 2 separate studies with compounds shown to have pleiotropic effects on muscle tissue. We ran an acute dietary study with a natural compound, Ursolic Acid, and an acute pharmaceutical study with an industry-developed monoclonal antibody. I'll discuss both of those a little bit more in a bit, just going through the design first. For the UA study, it was given daily until sacrifice, and study time points included 1, 2, and 4 week time points, or endpoints, if you will. For the monoclonal antibody, it was given as a bolus injection immediately after SCI, as well as at 1 week follow-up, and there was a 2-week study endpoint. So again, the general comparative groups will be sham, SCI, and treatment. So briefly, a little more detail on ursolic acid. This is a lipophilic pentacyclic triterpenoid, or generally speaking, it's a natural compound that is found in many fruits and herbs, such as apples, a plethora of field berries, a plethora of culinary herbs in the mint family, and via growth factor signaling, specifically in muscle, IGF-1, it has been shown to activate mTOR pathways to induce hypertrophy or inhibit atrophy, and in general, it reduces proteolysis. So we wanted to test in our model if it could have a general effect on preservation of body mass, as well as preservation of sublesional muscle mass, and see if this could carry forward to improve function. And our functional modalities were BMS, rotarod, and grip strength. And briefly, for the monoclonal antibody, the pharmaceutical was a selective anti-myostatin antibody, which I'm just going to call SRK. And it was developed by the pharmaceutical company Scholar Rock, who funded a pilot study for us to test this compound in our SCI model. Myostatin is a potent negative regulator of muscle mass. And again, we wanted to test some of the same things, preservation of body mass and sublesional muscle mass. And in this study, we were able to look at total body composition as well as total energy expenditure or metabolism, and also looking at functional outcomes. So with respect to the ursolic acid study, which I'll go over first, I won't show the biochemistry data just in the interest of time, but we did see strong, first of all, SCI-mediated reductions in mTOR pathway and mTOR signaling, as well as proteolysis that was attenuated by the ursolic acid. So that was great. But I will discuss the more general effects on pathology. So this is an analysis of, in the A panel in the top left, of body mass over time. And below you also have sublesional Soleus muscle mass over time. So in A, this is a typical body mass curve in our model where the SCI in red has this dramatic loss in mass, as would be expected, which is recovered by approximately 30 days. On the right, you can see the treatment with ursolic acid resulted in an increase in body mass that was significant as early as 10 to 14 days post-SCI. Notably, the vehicle control in this case is corn oil, which is very nutrient dense in and of itself. So you actually see an increase in body mass by about 3 weeks as well. This was not significant, but it is an important point. But to determine whether this could be in part attributed to preserved muscle mass, we harvested intact from tendon to tendon sublesional soleus muscle. And as expected, we saw an observed significant decrease in soleus muscle mass with SCI in red at all post-SCI time points. And also found that ursolic acid was able to significantly preserve soleus muscle compared to SCI and vehicle as well, again shown here in blue. Again, wanting to see if this would carry forward to functional outcome measures, we looked at our functional motor scores. Although seemingly higher in the UA groups, there was no significant difference in BMS scores at 2 and 4 weeks post-SCI. And perhaps this is expected, as ursolic acid wouldn't really be, I guess, anticipated to have direct effects or beneficial effects on the neural components as assessed by BMS. But we did see in the Rotarod time trial, which is a measure of motor coordination, there was a significant increase in the UA group, again in blue, at 2 and 4 weeks post-injury compared to SCI in red. And the height of the graph here would be time. And similarly, with hind limb grip strength, there was a significantly higher with UA, again, both at 2 and 4 weeks compared to SCI. Here, the height of the graph is force in newtons. So taken together, these provide evidence, these data provide evidence that support the potential for a compound such as ursolic acid to lessen muscle-specific pathology that is a consequence of SCI. There were, however, some limitations that we really want to consider, and I wanted to articulate here. Ironically, there's a compound of the model that you would not expect in the human condition or the human consumption of ursolic acid, and that was the need for ursolic acid to be dissolved in solution in this corn oil in our model. This was again directed by the literature, and a lot of other attempts to not use corn oil was failed. But we were wary of evaluating metabolism related risks using such a nutrient dense, I guess, vehicle, if you will. So we wanted somewhat cleaner way to do more advanced analysis with respect to intramuscular fat, total body composition, and energy expenditure. And this led us in the direction of looking at the selective myostatin inhibitor SRK, which I articulated a little bit earlier. And this project was facilitated by both Drs. Nash and Dr. Dietrich. So really briefly about myostatin. It is a myokine. It is produced and released by the muscle, and in an autocrine manner, it acts on muscle as well to inhibit muscle growth. So mature myostatin, or active myostatin, the mature form is the active form. It signals via the TGF superfamily of receptors, concurrently activating SMAD and AKT pathways to upregulate what are known as atrogenes or atrophy-inducing genes, and ultimately leads to proteolysis and muscle wasting. This mature myostatin is produced by 2 separate cleavage events, and our monoclonal antibody, SRK, selectively inhibits the second cleavage event, leading to myostatin being, I guess, stuck in the pro and latent form. So to confirm that we had target engagement, first of all, we performed Western blot analysis of the pro and latent forms of myostatin in various tissues from our experimental groups, and we found that in the SRK groups, there was this stark increase in the latent forms of sublesional gastrocnemius, supralesional tricep muscle, as well as in serum. And we did this just to show that there was this global effect that was happening. And the quantification below also includes sublesional Soleus muscle, because we did a lot of testing with Soleus as well. And we can see that the increase in the latent form for all of them is significant in all tissues, which confirms that the antibody is having the biological effect that is expected. So with SRK, similar to UA, SRK treatment results in a significant increase in body mass, the time points here being 1 and 2 weeks post-injury compared to SCI. And we also see, first of all, a significant decrease in sublesional gastrocnemius and Soleus muscle mass with SCI, and again, a significant increase in muscle mass with UA compared to SCI alone. So that's good. So additional studies we did actually looked at muscle or myofiber atrophy, as well as lipid infiltration in the Soleus. The upper panels here are H&E stained sections where individual myofibers were traced and the minimum ferrets diameter was analyzed. And this is essentially the cross-sectional area. In the lower panel, these were stained with oil red O to evaluate lipid content, similar to what we did with the aorta. And the graphs show that SCI resulted, as we would expect, a significant decrease in minimum ferrets diameter, as well as a significant increase in the neutral lipid stain, or the oil red O stain. And SRK was able to attenuate both of these effects. So these are promising effects because these conditions contribute greatly to the persistent metabolic issues that we see chronically in SCI. And we wanted to continue to look at some of these hallmark features of muscle pathology with SCI. And one of them is that phenotypic switch that I alluded to earlier. So we assessed the oxidative phenotype in the soleus muscle. Soleus is a heavily oxidative muscle normally, or type 1 slow twitch muscle. And it can be seen here by the expression of myosin heavy chain 1 in green in the sham animal on the left, in the left panel. 2 weeks post SCI in the middle panel, myosin heavy chain staining is completely gone, indicating a loss of this phenotype. And SRK in the right panel is able to rescue or save this oxidative phenotype somewhat. And this is really promising and could have a considerable impact from a rehabilitation perspective. So on the heels of those previous data, or the promising data, we now wanted to take a look at global composition, body composition or tissue composition, as well as metabolism. So as is pretty much the standard in human research, the DEXA was used to assess tissue composition, primarily parsing lean and fat mass. And DEXA is dual energy X-ray absorptiometry. For the mouse, in our mouse setup, some of the advantages are that we can do entire mouse imaging as we can in humans. It is fairly accurate with respects to bone, fat, and lean tissue. It's fast, under 5 minutes, and you can do live animal imaging. This is just an example of what the setup looks like, and an example of the image capture that you get, and an example of the output, which indicates, things that you input, such as animal ID, body mass, bone mineral density and content, as well as grams of lean versus fat tissue. So we look primarily at lean tissue because the effects of myostatin that we're looking for, we understand, are mainly on muscle, although myostatin does affect bone as well. And we saw here an expected significant decrease in total lean mass with SCI, and saw that SRK could significantly improve lean mass compared to SCI alone, supporting what we saw previously. So this was good. And similar to the DEXA, indirect calorimetry is one of the standards for assessing total energy expenditure or metabolism, global metabolism in human research. And this measures your oxygen consumption as well as your CO2 production, such that an exchange quotient can be calculated. And this is known as your respiratory exchange ratio. And this can be used to measure total energy expenditure or metabolism. This is an illustration of our calorimetric chambers that mice were placed in, so we could capture these gases. Mice were actually placed in the chambers for about 3 days, 72 hours, and the middle 24 hours were taken as steady state to calculate metabolism. And this is just an example of the output, which is measured continuously, so it's just a chunk of that. And the calculations that were used to generate RER and ultimately lead to a caloric value where we could get total energy expenditure or daily metabolism. And this is an example of our output and our results. In the top panel here, you can see that SRK, this is just an example, SRK treatment in blue results in greater O2 consumption. Again, this is over time. As well, in the lower panel, greater RER over time as well, and they should reflect each other. So the group comparisons, which for total energy expenditure then showed, as expected, a significant reduction with SCI in global metabolism. And again, SRK had an effect which was significant on improving global metabolism. So we have a significant increase in metabolism here. So to round out the experiments, we again looked at functional motor scores. And similar to the UA, there was no real effect seen with BMS. However, SRK treatment did significantly improve rotor rod performance by 2 weeks post-SCI compared to SCI alone, and improve grip strength performance at 1 week post-SCI compared to SCI alone. So overall, these findings provide evidence that support that this SRK, this selective myostatin monoclonal antibody, has a broad effects on physical, metabolic, and functional outcomes, and can lessen some of the SCI-specific pathologies that we see. So where does that really leave us? What next? When we evaluate what we can do next, there are essentially 2 paths, right? We can think of the follow-up studies that we can do to collect more salient data, which is always great, or we can discuss how translatable are these studies. So for the experimental studies, we felt that further work with Ursolic acid in the model would be difficult in overcoming that confound of the corneal, especially because we're looking at metabolic outcomes. But we do feel that salicylate, for the salicylate study, more comprehensive and sensitive testing for the inflammatories, those analysts, as well as more robust modeling, could be used in substantiating some of these novel determinants of disease, as well as evaluating what an extended treatment protocol would look like with respect to disease. As well, we also currently have a Dod funded study for SRK, which is considerably more complex, that we're performing longer time series analysis where we actually get into the chronic time points. We're evaluating prophylactic versus treatment effects of SRK, and also looking at the effect of high-fat diet on metabolic outcomes and all these interactions, specifically because high-fat diet is a confound that is well noted in the human population. But importantly, these projects, they were very purposeful, and they were strategic in the way they were positioned so that we could more seamlessly redirect to human trials. For example, salicylate, it's an NSAID, it's available as a generic with known safety. This is something that can be transitioned with a new off-label IND for the SCI population, actually more readily than other drugs could be. For the Ursolic acid, this is a natural compound. This is something that's an FDA-approved supplement already. We wouldn't require any IND filing to run any studies. We could easily integrate this into an acute dietary trial. We have a breadth of experience with these types of dietary interventions. And for the SRK, it is something that is actually currently approved for safety and efficacy trials, and on label for spinal muscular atrophy. So we would require a new off-label IND and some more safety testing. But again, having this partnership with the pharmaceutical company, the preclinical publication, as well as the ongoing DoD, we think we have a strong case to move forward with this. So I gave an overview of a lot of highlights of different studies, just so we could show or illustrate that what we've done is brought 3 potential opportunities to directly move our own preclinical work to human trials. And this is really important to us because, again, as a translational center, I think it's a valuable thing to evaluate how our work has the ability to serve our own clinical population. So that was really the goal of trying to move these forward. So this is just a brief acknowledgement slide for the lab, our collaborators, and the facilities. And some of the citations that I included in the background. And at this time, I'll take any questions. So I see one from Dr. Dietrich right away. Do you evaluate heart tissue in these studies? Yeah, so the only, Dr. Dietrich, the only heart studies that we did was the biochemistry, where we looked at the leptin and signaling pathways, just because biochemically they had been shown in other models to lead to cardiac dysfunction, but we actually didn't look at heart physiology, if you will.
Yeah, thank you. Great talk, Greg, and congratulations to you and your colleagues. The more and more we're looking at the holistic consequences of spinal cord injury in people, you know, it's multi-organ. It really is, and you and your colleagues, Mark, have really opened the door to looking at these multi-organ consequences of spinal cord injury, and of course the other factors such as obesity and other areas that you're studying. So yeah, so more and more of our research recently is targeting after brain injury or spinal cord injury. It looks like the cardiovascular system is affected, and we know that from the clinical arena. So I was just asking about any direct evidence that, for example, the cardiac muscle is showing evidence of increased neuroinflammation, or I shouldn't say neuroinflammation, but inflammation that could be affecting the function and outcomes. So that's why I asked that question.
Yeah, so that's a good question. There's a lot of stuff has been done, I think, with the stroke literature more than SCI specifically looking at inflammatories. But it's interesting because coronary artery disease or atherosclerosis is primarily an inflammatory disease anyways. So just by default, you're seeing these inflammatory cascades. So I don't know. Parsing them out might give you the same result and show you the same thing, that it is not strictly, but primarily an inflammatory issue that's happening. And some of these other biochemical pathways that, you know, that we're parsing out with the leptin is pointing to the exact same things, right? Like the TNF alpha, the IL-6, the IL-1 beta, so on and so forth.
Very good. Thank you.
Thank you.
Hey, Greg, I've got a couple of questions. One is, you know, you showed kind of a whole array of really nice outcome measures that were positively affected by, you know, these multiple compounds. But you just alluded to like heart physiology and some other measures that could be, I guess, really relevant to quality of life. So, for example, if you reduce, you know, oil neutral lipid deposits in the aorta, that's great. But at the end, you want to measure heart function, right? Or you know, you had a nice graph about life expectancy for the patient population. And so are these some outcome measures that you're kind of talking about with the pharmaceutical company or kind of in your own lab about what would be, so if this were to go to clinical trials, you know, what would be really the most relevant outcome measure endpoints that would be applicable?
So it's a good question, and I think there's a few separate answers to that. So with respect to the salicylate and the aortic lesion, first of all, that was important to show how SCI actually accelerated disease formation there, right? So in that sense, for what we wanted to see with salicylate, or we wanted to show just with the actual tissue staining, is that there is something that needs to be done earlier, and we need to test these anti-inflammatories earlier. So the outcome would be the potential there is to earlier intervention to reduce disease. With respect to with the pharmaceutical, the SRK, that actually is really, I think, probably addresses your question a bit better. So what we have with sublesional muscle is, you know, this is really decentralization, right? Not denervation, if you will, like the contusion injury. And you have this atrophy of tissue and this lipid infiltration. Not only do you have lipid infiltration, you have this fiber type switch. Those are two really important things. So that switching of fiber type from type 1 to type 2 is for energetic properties. It's more energetically efficient. So this actually really limits some of our in-house rehab modalities, such as FES, because of the size principle of muscles and the amount of stimulation that's required in fatigability. So if you can actually have a compound that preserves muscle size, first of all, or limits that fiber type switch early, that an early intervention may make those modalities more beneficial. And especially when you think of things like incomplete injury, right? That and the fact that if you can reduce the infiltration of fat into these tissues, you're actually preserving that tissue longer. So you're offsetting some of these metabolic effects. So those are some of the more long-term things that we really want to look at. Like, if we can preserve this muscle, what are the longer-term effects that we have on some of these global metabolic measures? Or just from a rehab point of view, can this be something that potentially makes our current modalities actually more useful? Does that somewhat address your question?
Yeah, I get it now. Right. So if you can preserve muscle, and especially bone density, then there's a lot more rehab options that's so right. So you would couple this with some rehab or electrical stimulation where you would really need muscle to stimulate, right?
Right. Like, and this is that's exactly it. This is one of those things, like, and it just hasn't been looked at through this lens, right? We think of preserving muscle, and we just think of the functional outcome measures that we want to see, i.e. walking, right? But this actually may create better utility for our rehab modalities that we currently use going forward.
Yeah, that makes sense. My other question is, of these cardiovascular dysfunctions, metabolic dysfunctions, is there a correlation with the injury level? So, for example, higher the injury level, are these comorbidities more severe?
Yeah, so they will. I guess part of that I can only anecdotally answer, because we haven't done like different level of injury, and we're the only group that's actually showed this as far as disease. But I think the conjecture is yes, that there's more disease earlier with higher levels of injury, and we do see this with postmortem data from the human data. We actually didn't do higher level because we couldn't get these are longer survival times, and we just had too many mice dying that were basically functionally sympathectomized at like T6, if you will, and higher. So we used T9 because we still have, good splanchnic innervation to the viscera. So we could say that there would be dysfunction there. And thankfully our results showed as much. But yeah, I would suspect it would be much higher.
So there's no data on the clinical population about whether cervical injuries lead to worse metabolic dysfunction than lower thoracic?
Yes, with proxies, with those proxies and outcomes that I discussed earlier, there are data that show that. But again, it's like a separate question, because those proxies actually don't address disease, right? Because you don't really look at disease that much until after the fact. But yeah, they present quicker or sooner, and with more or worse risk factors. So you're going to see impaired fasting glucose sooner or higher levels sooner. Obesity I won't touch too much, because there's we've already kind of reevaluated how we're clinically looking at that in SCI. But yes, things like insulin resistance for sure, dyslipidemia with respect to HDL specifically, all those things are higher and sooner the higher level of injury, specifically once you get T6 and above.
So do they know whether that's attributed to reduced sympathetic flow, or just because cervical injuries, you can't move as much than thoracic injuries?
I think it's a great question, right? Like I don't know if there's not a lot of work that parses those out. too much. I think, again, one of the things that we wanted to look at initially was that, thinking about sympathetic outflow, right? But we just couldn't get our animals to survive long enough. But I think that it's a great question that I don't have the real answer to.
Okay, thanks.
Is that it?
That must be it, Greg. Thank you very much.
Thank you, guys.
Greatly appreciate it. Bye-bye.